So I think, hello everybody. I guess it's time. We have now the opportunity to start the ACHD national rounds, and it's my pleasure to chair these rounds together with Sarah Blissett. Maybe Sarah, if you're also present, maybe you can also just introduce yourself, please.
Thank you so much. This is an exciting opportunity for us to branch out with these national ACHD case rounds that are organized by CashNet. We've been doing this for our second year, discussing topics that are relevant for non-ACHD specialists with the aim of highlighting diagnosis and management strategies aligning with the best evidence. And there'll be a panel that will also contribute to a lively discussion, I'm sure.
Well, I think I just let you introduce the panel, maybe. So just go ahead, please.
Absolutely. So Dr. Jasmine Grewal is joining us. She's the president of CashNet, as well as Jonathan Windram from the University of Alberta. And Dr. Rafael Alonso hopes to join us this afternoon. We'll see if he's able to. So it'll be a great, diverse discussion.
I'm here.
Oh, thank you so much.
Perfect. So I guess the structure of this session is we have actually two cases dealing with pulmonic valve problems. Both cases will be presented by Dr. Joanne. She's a fellow here with us at the Heart Institute. She will soon join the Toronto team to start additional training in ACHD. She will present one case, then we have a discussion followed by the case resolution. Then I will give a short, brief talk about the assessment of valve function on echocardiography. And then we have a second talk again about the second case about the pulmonic valve problem, again followed by discussions. And in the end, we have time for questions and answers before we conclude the session. So I think it's now my pleasure to introduce, Joanne, and she will give us hopefully the first talk about the first case with a valve problem, with a pulmonic valve problem. Please, Joanne.
Hi, everyone. Thank you for the opportunity to present. I'm just going to share my slides very quickly. Teams is giving me trouble, I think. I don't think you can see my slides.
We can't yet. Oh, now they're coming, Joanne.
Awesome.
There they are.
Are they in presenter mode or just the normal mode?
They're okay.
Normal mode.
Okay, excellent. Awesome. Thank you so much, everyone, for the opportunity to present. And as Dr. Schwerzmann said, this is the agenda for the session. So we'll get started with case one. This is a 27-year-old male assessed at a general cardiology clinic due to heart murmur, noted by the family physician. He has no cardiac symptoms or exercise intolerance. His past medical history is significant for deviated septum, secondary to a nasal trauma, no medications, no family history of congenital heart disease. He's married and no significant social risk factors. His echocardiogram on presentation shows moderate to severe pulmonary stenosis with a peak gradient of 55, no pulmonary regurgitation, mild to moderate right ventricular hypertrophy, and normal biventricular size and function. He is assessed at a ACHD clinic, and in the absence of cardiac symptoms, there was no plan for intervention. The patient was planned to have a repeat echocardiogram and a follow-up in 1 year, but unfortunately, he was lost to follow-up and represents 5 years later at the age of 32, and he continues to be asymptomatic. His echocardiogram shows that he has severe pulmonary valve stenosis with peak gradient of 65, trace pulmonary regurgitation, normal RV size, normal systolic function, normal LV size, and normal systolic function. He undergoes a cardiac MRI, which shows normal biventricular size and function again, RVH as expected, thickened pulmonary valve leaflets with prominent flow acceleration and trace pulmonary regurgitation. His pulmonary arteries are normal in size with patent branch pulmonary arteries. He undergoes a cardiopulmonary exercise test, which shows that he's able to exercise for 10 minutes on a fast ramp protocol with an RER of 0.15, indicating maximal effort. His peak VO2 is 37, and overall no cardiopulmonary limitation secondary to his pulmonary disease. So once again, he's lost to follow-up, and this time around represents 3 years later at the age of 35, and he continues to be asymptomatic. His echocardiogram now shows severe pulmonary stenosis with a higher gradient of 74, with normal RV and LV function and RVH. And this time his cardiopulmonary exercise test shows that he's still able to exercise for 11 minutes, but the ECGs show that he develops a right bundle branch block with ST depression during exercise that quickly resolves within 1 to 5 minutes, RER of 1.2 indicating maximal effort, and peak VO2 of 35, and overall, once again, no cardiopulmonary limitation. So now I would like to turn to the panel to ask them, in this patient who is asymptomatic, is pulmonary valve intervention indicated? Is additional imaging needed? And if intervention is planned, should we consider percutaneous balloon valvuloplasty or surgical pulmonary valve replacement? How would you follow this patient if he was to receive a pulmonary valve intervention? What complications should we expect? And if this patient was a woman, how would we counsel her for pregnancy and contraception?
That's a lot of questions.
That's probably we need the rest of the hour just only to go through these questions.
Do you want to go first, Rafa?
Yep.
I can give it a go. So I mean, in terms of indication of the pulmonary valve replacement, the patient is asymptomatic, but the RVSP is high, and all depends what you are planning to do. If the valve is, if this was my patient and the valve is amenable for a percutaneous balloon valvuloplasty, I would, and there is no significant regurgitation. I haven't seen the picture, so I just with only the report that you just shared, I would probably offer him a balloon valvuloplasty now, just to save some time to that valve and gain and avoid to have to develop RV hypertrophy that could go, could lead to a restrictive RV in the future and would be a problem. So that's what I try would offer, just because the RVSP is just more than 64, which is the cutoff for the European guidelines to do something percutaneous. Would I offer him surgery right now? I wouldn't. Would I offer him a percutaneous valve right now? Probably I would think about it. Probably not. I would wait for it's a native outflow tract. I think that being asymptomatic and being this young probably would wait if I cannot do a balloon valvuloplasty. How to follow him as I go the first, I don't think we need much more additional imaging in terms of, we can make the decision with a good echo. If patient receive a pulmonary valve intervention, well, I would just, if it's a balloon valvuloplasty, I would monitor him every year as you can do, and then complications that he can develop is pulmonary regurgitation from a pulmonary. He can develop pulmonary stenosis again. And I will leave. I can talk about the pregnancy, but I think the rest of the panel need to talk too. So
Thanks, Rafa. I can add a little bit as well. So completely agree with all of that. And I guess the only other question I would have or comment is, the main driver to do anything here would be the RVSP. He's asymptomatic. Exercise tolerance is preserved. And so, I do wonder about getting a cardiac catheterization to really look at the hemodynamics closely. And then you're looking at, depending on which guideline, like more than half, RVSP more than half or 2/3 of the LVSP would be, an indication to do something strictly based on, like Dr. Alonso also already indicated, those right-sided pressures and potential RVH arrhythmias related to that. And then I guess depending on the intervention, like you said, it's a native outflow tract. If you were then thinking, depending on the hemodynamics of intervening, the intervention you could consider a cardiac CT to better look at that. If you were thinking, if valvuloplasty wasn't an option, you were thinking about a transcatheter pulmonary valve option, then CT could be considered. But that's, all the way down the line, depending on whether you're going to do something and if so, what that would be. Maybe I can leave the pregnancy one for Jonathan. Although I love talking about pregnancy, but
yeah, I agree with all those comments. I think when it comes to the pregnancy part, just for the same reasons, I mean, it's going to get worse in the pregnancy. Though generally, like severe pulmonic stenosis is very well tolerated in pregnancy. For the same reasons, it would be better to go forward for a percutaneous pulmonary valve prior, so that you're going to reduce the risk of the patient being symptomatic in the pregnancy. Though, as I say, it's relatively well tolerated. I don't see that people might think about MRI to look at the RVH a bit more detail. I don't think that moves the needle. I'd agree with Rafa. Just generally in patients like this, I think we get all the information that we need from the echo and the CPET.
Maybe if I may ask a question, I think both Rafa and Jasmine, you both talked about the RVSP as threshold as criterion for intervening, but assuming, I don't know, I don't recall, I think this patient hasn't any degree of tricuspid regurg, we just have the peak gradient across the RVOT. Would you also be confident to just use the RVOT gradient, or what would you do in this case?
Jasmine, you are on mute.
Yeah.
Yes.
I was just going to say, I think I alluded to it before, that I would get a cath if you were seriously considering intervening, especially in somebody who's completely asymptomatic, preserved exercise capacity. I'd want to confirm the hemodynamics on a cath and before doing something based on that echo number.
I think it's reasonable if you think to do something. Last thing, but if you have isolated pulmonary valve stenosis just on the leaflet level, I think the pulmonary gradient is a good criteria. You're gonna cath the patient anyway for the balloon valvuloplasty if you decide to do one. So probably I would assess the pressures before the balloon, and but I would be ready to balloon that valve in the catheter if the numbers are high. I would not do a catheter and discuss him again. Just I put a catheter, and of course, if the catheter doesn't show what because of course, if you have a tandem stenosis, you cannot use the number. But if it has isolated valve stenosis, normally it's quite reliable. But I agree with Jasmine. I would do a catheter, see what the numbers are. If the numbers are okay and the valve was already favors a balloon valvuloplasty, I would offer a balloon valvuloplasty. So it's just something that we don't think in adults, but it's something that I use quite a lot every time I can, and you can save a lot of time.
I'd also say that, remember, it's on the new ACHD guidelines, it's a 2A indication.
Yeah.
I'm curious the role of stress echo in these patients and looking at their RV and how it responds to exercise. Is that something that you've considered in these patients who are asymptomatic?
To be honest, I wouldn't do it. It's just gonna get worse, and I don't think it really helps. But I haven't used it, but I'm interested to see what you've done, Rafa.
So my opinion with the stress echo and right-sided lesions, mainly in primary stenosis, you don't have data. It's going to always increase cardiac output, and your RVOT grading is going to be probably 100 and something. And then you don't know what to do with the number, because really we don't have data. We cannot really, normally it always gets worse. I don't really know how to interpret IC on exertion in absence of symptoms. You know, it's difficult. So I don't really normally use a stress echo in this setting. It's very unusual to see a drop in RV function because of a severe stenosis, you know, so.
Well, Joanne, do you want to tell us what happened in this case and how you proceeded?
Yes, of course. So the patient underwent a TE-guided percutaneous valvuloplasty, and this is the pre-procedure TEE that shows flow acceleration across the pulmonary valve. And intra-procedure, you could see the wire crossing through the pulmonary valve there, and the balloon being deployed as part of the intervention. And post-procedure TEE shows significant reduction in the pulmonary valve gradient to a peak of 10 millimeters of mercury. And a post-procedure surface echo shows reduction in pulmonary stenosis, again from severe to mild, and a slight increase in his pulmonary regurgitation from trace to mild, and consistently normal biventricular function. The patient has continued to do well and is asymptomatic, and is planned to have repeat echo and ECG in about 2 years.
Very good result. A great example of the use of valvuloplasty in adults.
Yeah, beautiful.
Mm-hmm. Okay, so thanks for your first case, Joanne. In between the two cases, Dr. Schwerzmann will tell us a little bit about the echocardiographic assessment of the pulmonary valve in more detail. We'll have him share his slides and we'll transition.
Okay, thank you very much. Let's see if I can manage it. Yep, I think you can see my slides.
Yes. It's just going into the slideshow mode now, I think.
Okay, so that's just, I have to switch the, I think now you see the slides, I hope so.
Yes, it's perfect.
Okay, so actually Luc Mertens was, I was first thinking about Luc Mertens to ask him to give this talk, and unfortunately he's on travel, he's traveling this afternoon, so he wasn't able to join us. So I was jumping in, and I think when it comes to the assessment of pulmonic valve function, we really have also to think about how we define the severity of a valve lesion. If we look at the anatomy, be it the valve opening if we have a stenotic lesion, or be it the regurgitant orifice if we have a regurgitant lesion, or do we focus more on the hemodynamic consequences, meaning the transvalvular gradients or the regurgitant volume? And we all know that typically in left-sided lesion, there's actually quite a strong correlation between the regurgitant orifice and the regurgitant volume. If we think about regurgitant lesions like mitral regurg, so actually we can usually assess, if doing PISA, we can assess the regurgitant orifice, and the resulting regurgitant volume is usually in the same level of category as we would quantify the severity if we rely on the PISA. So in left-sided lesion, that's typically not such a problem. But interestingly, also in left-sided lesion, actually the correlation between regurgitant volume and regurgitant orifice depends on what I call driving forces. And I would just like to use an example, an excellent paper published 14 years ago by David Mesika, who now is our director in the Valve Clinic. And one of his fellows actually looked at the correlation between regurgitant volume and regurgitant orifice in 240 patients with mitral regurg, and 140 of them had actually prolapse or organic mitral regurg, and roughly 100 had functional mitral regurg. And the ones with the prolapse, that's the one that the dark dots, you can see they have, again, an excellent correlation between regurgitant volume and regurgitant orifice. And also the white dots, the ones with functional regurg, have quite a good correlation. But what difference between these two groups is actually the slope of the correlation. And when they did further analysis on what was actually influencing the slope, they looked at ejection fraction. They looked also at systolic PA pressure, and systolic PA pressure is most likely also affected by the increased left atrial pressure. And when looking at these different factors, they actually found that the most important variable affecting the slope of the correlation was systolic PA pressure, and more likely the underlying increase in left atrial pressure. So it looks that also in left-sided lesions, actually the driving forces between the regurgitant chambers, between the left ventricle and the left atrium in this case, or if we go to pulmonic regurg, between right ventricle and PA, can actually affect the correlation between regurgitant volume and regurgitant orifice. And as you can easily see on this slide, we have on the left side the pressure curves of the aorta and left ventricle, and on the right side the pressure curves between the right ventricle and the PA. And these driving forces obviously are much more bigger on the left side than on the right side. But this also means that subtle changes in these driving forces will have a much bigger impact on the right side than they have on the left side. And what does this mean? This means that if we really have severe pulmonic regurg, we usually see at one point in time a pressure equalization between the PA and the right ventricle, terminating regurgitant flow. And the driving forces are, of course, the PA pressure and the RV pressure. And so if we have an increase in these driving forces, let's say in the presence of pulmonary hypertension, then I think we will see more regurgitant volume through the same regurgitant orifice as we would see with lower pressures. On the other hand, if we have increased filling pressures, we can expect to see an even earlier termination of regurgitation. And this means we will have less regurgitant volume. And so I think these confounding factors really have to be kept in mind when we try to quantify the degree of pulmonic regurg when looking at regurgitant volumes and when looking at regurgitant orifice. If we go to the guidelines, and if you look at the guidelines how to quantify pulmonic regurg, then they actually say, well, we should be quantitative whenever possible. And this means usually, if we can, we should try and measure regurgitant fraction. This can be done by QPQS. But as we all know, in patients with right-sided lesions, it can be quite challenging to have really an accurate QPQS. So this means most of the time we have to look for other signs, and other signs can just be we look at the structure of the pulmonic leaflet, and if the pulmonic leaflet is really disrupted, then we can expect to have severe pulmonic regurg. If we have a huge right ventricle and no other lesion, we can also assume that the right ventricle enlargement is because of significant pulmonic regurg. We can look at the pulmonic, at the branch PAs, flow reversal, and then we can also look at certain signs that actually indicate how fast pressure equalization happens between the PA and the right ventricle. And so these are the slides now of a typical patient with severe pulmonic regurg, and the qualitative markers we usually use to identify severe pulmonic regurg is, as I said, we look at diastolic flow reversal in the branch PAs. We look at a short pressure half time, and usually a pressure half time of less than 100 is considered to be severe. We can look at the density of the signal. We expect the regurgitant density to be more or less of the same density as the forward volume. And we can also look at the no flow time, or also another marker at the ratio between the regurgitant time and the whole diastole, and the earlier the flow termination, the shorter this kind of ratio. And if we look at all these different types of markers of PA, as you can see, some have better and some have less specificity. And one of the markers with, let's say, the highest specificities are really actually the diastolic flow reversal in the branch PA, not necessarily in the main PA, but in the branch PA. Then really a long no flow time expressed by a short PR index or a no flow time of more than 80 milliseconds. And the pressure half time, actually, if you look at the pressure half time, you can see the pressure half time has a pretty bad specificity. It seems to be sensitive, but not really helpful to identify severe pulmonic regurg. And if you look at the studies actually supporting this kind of concept, then you can see the challenge with the pressure half time. If you look at pressure half time on echo versus regurgitant fraction on MRI, that actually the pressure half time in mild pulmonic regurg is typically above 100 milliseconds, but the pressure half time in moderate to severe pulmonic regurg, when defined by regurgitant fraction on MRI, is actually quite comparable. So the pressure half time actually can be used to exclude mild pulmonary regurgitation, but it's not really helpful in distinguish between moderate to severe pulmonic regurg. And so if we look also at the MRI, then we really have to keep in mind that echo and MRI doesn't tell us the same thing. It both gives us number regarding pulmonary regurgitation, but it looks at different aspects of the lesion. In echocardiography, I think we look mainly on the driving forces between PA and right ventricle, on how fast pressure equalization occurs. And on MRI, we look mainly on RV enlargement, on regurgitant volume and regurgitant fraction. But on MRI, we have more challenges to take into account the confounders of regurgitant volume and regurgitant fraction, and this means the underlying filling pressures and the PA pressures. And that's one of the beauties of the echocardiography. Then in echocardiography, we can also actually assess, let's say, the driving force of the pulmonic regurg. And so one of the markers we have to think that RV filling pressures might be elevated is actually to look at end diastolic pulmonary valve forward flow. If we see here constantly over the whole respiratory circle a wave, meaning atrial contraction alone is sufficient to push blood across the pulmonic valve, then this is usually can be used as a sign of increased RV filling pressures. We can, of course, also look, as we always do, on the IVC, at the sniff, and based on IVC diameter and collapsibility, we can estimate rate atrial pressure as 3, 8, or 15. Or what we can also do, and what maybe we don't do so often, we can actually take a look at the hepatic veins. And I think we all are quite familiar with the pulmonic vein and with the pulmonic veins, and now with the new definition on how to assess diastolic function on the LV side, the pulmonic veins have again a more prominent role. But we know, like in this picture that I show you here, in patients with increased left atrial pressure, what we see on the pulmonic vein signal, we see a decrease in systolic flow, an increase in diastolic flow, and markedly an increase in flow reversal during atrial contraction. And the same findings we can also see in the hepatic veins. In a normal hepatic vein profile, we can expect the systolic component to be higher than the diastolic component, and we don't have really so prominent flow reversals. On the other hand, if we have increased right ventricle filling pressures, we can see actually a decrease in systolic flow or an increase in diastolic flow, and we see marked flow reversals, especially during atrial contraction. So I think that's one of the beauties of echo, and it really gives us also some more information about filling pressures, and knowing filling pressures, but also knowing, let's say, the presence of pulmonary hypertension helps us to better understand how early actually pressure equalization is assumed to occur, and may us help to better assess if a given regurgitation or a small, let's say a small regurgitant volume on MRI may actually be just due to early termination as seen on echocardiography. And that's why I guess if we really want to assess pulmonic regurg comprehensively, we need actually to rely on echo and MRI. In some cases on echo, the findings are clear and there's no doubt, but sometimes you also have to go back to MRI. But we have to keep in mind that really echo shows us more about the regurgitant orifice, or let's say the speed of pressure equalization reflecting regurgitant orifice, and MRI shows us more about regurgitant volumes, regurgitant fraction, but this can again be affected by filling pressures. So if you go now to the assessment of stenosis, then I think the challenge we have again on the right side compared to the left side is that on the right side, especially in the congenitals, we are more likely to encounter, let's say, serial obstructions. We can have an obstruction on the infundibular muscular level. We can have valve obstruction, or if the patient has already a conduit, we can have a conduit obstruction on a valvular level, or at the supravalvular distal conduit. We can have branch PA stenosis, we can have branch hypoplasia, and all these factors actually affect, of course, the degree of RV outflow obstructions. Assuming that we only have a one single discrete stenosis, like in isolated pulmonic valve stenosis, then, as Rafa said, we can actually look at the peak gradients, and usually we call less than 36 millimeter mercury mild and more than 64 millimeter mercury peak gradient severe. On the right side, we usually look at the peak gradients and less at the mean gradients. But things get much more complicated if we have not just a single focal lesion, but if we have, let's say, like here, a diffusely stenotic conduit, or if we have serial obstructions, be it on a valvular level and on a distal conduit level. If we have this kind of complex anatomy, then the simplified Bernoulli equation that we use for the valve lesions do not apply anymore. And then, as mentioned by our panel, then we have to look at the RV systolic pressures, and just the peak gradients across the RVOT cannot be used as a reliable marker of stenosis severity. And if we look at the TI gradients and the RVOT gradients, then we can actually encounter like 3 different scenarios. We can have scenarios where the TI gradients are much higher than the RVOT gradients, and this means the RV hypertension or the RV pressure is actually higher than as indicated by the RVOT gradient, and we may likely underestimate the degree of stenosis, be it because the patient may have multiple stenosis, branch PA stenosis, or may also have one component of pulmonary hypertension that's not been taken into account. If we have TI gradients quite close to PA gradients, then we are also confident knowing that the PA gradient actually reflects the pressure load to right ventricle. And then we have scenarios where we have a TI gradient that is much or is lower than the PA gradient. And this means the county gradients we measure overestimates the degree of stenosis. And this is the typical scenario we encounter in diffuse narrowed conduits. And so because of these challenges, if we look at the different guidelines, and if you look at 2020 guidelines, like Rafa said, then actually in these scenarios, the guidelines don't rely on the peak PA pressure, but they rely actually on the RVSP to guide treatment decisions. So just to show you a few examples. So here we have the example of a patient with a Gondry gradient of 45, and the gradient looks quite reliable. But if we look at the TI gradient, then we have a TI gradient of 77, meaning that just by focusing on the Gondry gradient, we really underestimate the pressure load to right ventricle. And in this scenario, what we have is we have a RVP, a Gondry gradient of 73, and also a TI gradient of 71. So both gradients are more or less congruent. And this also, I guess, gives us some affirmation that the numbers we measure across the Gondry are more likely to be the true gradients. So my facet for grading the pulmonic stenosis is that in discrete lesions, we can make treatment decisions based on peak gradients, but we have to be aware of the limitations of the simplified Bernoulli equation, and this especially applies to Gondrys and especially applies to serial stenoses. And in patients with a Gondry, a peak RVOT gradient alone is an unreliable measure of the RV load. We really have to try to measure the RVSP to assess pressure load. And we also have to keep in mind that in these patients with pulmonic stenosis, if the RVSP is increased, this doesn't mean the patient has pulmonary hypertension. It means the patient has RV hypertension. And the reason for RV hypertension can be to some degree pulmonary hypertension, but can also just be because of a valve stenosis or a branch PA stenosis, or can be for many different reasons. Okay, this was my brief summary on the echo assessment in pulmonic valve, regurgitant, and stenotic lesions. And yeah, if you have any questions, please feel free to write in the comment section, and then we can discuss it at the end in the Q&A section. Thanks a lot.
Great. Well, thank you for that outstanding presentation. It's a great setup for Joanne's second case of pulmonary regurgitation.
All right. Thanks, Dr. Schwerzmann, for that excellent talk. So case 2 is a 20-year-old male followed in the ACHD clinic with pulmonary regurgitation, post balloon valvotomy as a neonate for congenital pulmonary stenosis. He has no cardiac symptoms, has a history of asthma on budesonide puffer. His echocardiogram shows mild pulmonary valve annular dilation with dysplastic pulmonary valve leading to failure of coaptation, no pulmonary valve stenosis, severe pulmonary valve regurgitation, and moderate pulmonary artery dilation. His echocardiogram shows severe RV dilation with normal function, no significant tricuspid regurgitation, normal right atrial pressure, and normal LV size and function. His cardiac MRI 7 months later shows a moderate pulmonary regurgitation with a regurgitant fraction of 42%, which is different from what was seen on echo, which stated that the regurgitation was severe. He has severe RV dilation with now moderately reduced systolic function, normal LV size and function, and dilated main pulmonary artery with patent branch pulmonary arteries. His cardiopulmonary exercise test shows that the patient is able to exercise for 16 minutes with an RER of 1.11, indicating maximal effort. His peak VO2 is 48 with 100% predicted, normal resting oxygen and exertional oxygen, and overall no cardiopulmonary limitation. So question to the panel is, how do you reconcile the discrepancy in echo and cardiac MRI findings regarding pulmonary regurgitation severity and RV function? What is your approach in patients with severe PR after repair of pulmonary stenosis versus patients with tetralogy of Fallot? Do you treat them differently? And what would be your cutoff for RV size, for example, to intervene in this case? And if intervention is planned, would you prefer to do percutaneous pulmonary valve replacement or surgical replacement? And how do we follow these patients, and what type of complications should we keep in mind? And finally, if this patient was a female, how would we counsel them on pregnancy and contraception?
Jonathan, you want to start?
Yeah, Joanne, can you take us back to your slide showing us the
MRI numbers.
showing the numbers on the MRI? Because Ian's made a good point. You know, a regurgitant fraction on MRI of greater than 40 is severe. So, you know, I see this and I say that there's severe pulmonic regurgitation. And so if you can go back to the next one, the one before the echo findings. Yeah, so I mean, this is severe pulmonic regurgitation on MRI as well as, and so there isn't a discrepancy. I don't see your pictures too. I mean, the RV looks pretty good there, but I'm only seeing part of the outflow tract. Yeah, there it looks.
But it definitely looks dilated, though, right? I mean,
it's certainly severely. It looks severely dilated.
Can you go back to the MRI for a second?
Yeah, you don't have any MRI images, unfortunately. There is a discrepancy in your measurements between the two. One of the things that you should always do is when you're doing the MRI and let's say you're reading it and someone else has read it before, you should recontour the prior study from 3 years ago. That should be standard practice, and there could be quite a difference even in just one basal, and just like the way you take that basal measurement, you can get quite a big difference in volume between two readers. I know we always say it, you know, MRI remains the gold standard, but those of us who do MRI quite frequently see those things. I mean, based on this, there's a lot of good reasons why we would give this new guy a new valve. His function's gone down. He's in the setting of severe PR. But I would be looking at remeasuring some of these myself, given the discrepancy in the end diastolic volumes the end systolic volume as going up, but the end diastolic volume going down doesn't really make much sense. Thoughts, Mary?
That was one of my comments. I think if it's not possible to have it's possible to have a bigger end systolic volume, but not possible to have a smaller end diastolic volume. So one of the two is wrong, either the first or the second. Not saying that this is exactly the second, but I would find difficult to rely on the diastolic number for that. Definitely the ejection fraction is worse, but also your ejection fraction depends on your volumes in the MRI. So
Exactly.
so you're gonna have to re-measure that in order to make a decision. So that's the, if you trust your end systolic volume, that is a significant change in scary volume, if that is true. And I think 42% regarding fraction in the MRI is severe. If the cutoff is 40, as and therefore I don't think it's a discrepancy in the severity. A discrepancy, if you go back to the echo, just put the echo picture moving. So I mean that LV that RV doesn't look 32% on a single picture. That's a single 4-chamber view, but that looks quite good. Which, if you have underestimated your end diastolic volume, your MRI, could explain why your ejection fraction is low. It's just because you just don't have, you have a smaller end diastolic volume and you have a bigger end systolic volume, so you get a ejection fraction that is lower. Doesn't seem the echo like that. So I think that's as Jonathan said, the MRI is gold standard, but you have to put all together. Can you go back to
we just, sorry to jump in, but like in that view, we might be missing a big aneurysmal RVOT patch. Right?
Yeah. So that I'm just saying in this picture is, even if you have a big aneurysm RVOT patch, is my 32 seems to be very low. Can you go to the questions? So I think that we answered the first one, right? So we just think that the severity is probably the same. The function probably is technical, or we don't know, but could be a technical issue. So second, what is your approach in patients with severe PR after follow repair of PS? I think that's a very good question, and excellent and different in the guidelines, and I think we cannot use the same criteria for cutoffs in terms of volumes. We can discuss here whether even we should use volumes to change valve. That's a discussion altogether. But let's assume that we use volumes and we believe in volumes, and then the cutoffs cannot be the same when coming to the diastolic cutoff. So the diastolic, definitely, we look into this in our cohort of pulmonary stenosis, and we found that actually the cutoff of diastolic volume that you need to get back to a normal volume in the RV is around 195. But what is interesting, the end systolic is the same. So in our cohort, the end systolic volume was 80, as it is in the phallus, which makes sense because an end systolic volume that is large just indicates that you have a problem with contractility. So that normally goes along with a decreased ejection fraction, but definitely you cannot use the same criteria. The volumes are different, the ventricle is different, and we are more, or I'm personally more permissive with PS that has a severe PR. I'm not as worried for a long diastolic volume that is large, but I'm equally worried for an end systolic volume that is large. That definitely. The end systolic, and this is one of the changes of the new guidelines. They got rid of the end diastolic volume, which we can argue whether it's right or wrong to be done. But definitely, if you look at all the papers in phallus that has given different volumes. For 170 was the first paper in Toronto, to 150. There's another paper from the Netherlands. And everything in between with 160, all of them have exactly the same end systolic volume, which is 80 or 81, all of them. So I think that the systolic volume, that's why it's kept in the guidelines, and it's very reliable, and it's reliable in both lesions. And that's, I think, is very, very helpful in my opinion. I think that with if that systolic volume in this patient is true, even having a normal exercise test, I would definitely offer him a pulmonary valve replacement. I don't know, before going to the next question, if anybody has an opinion about this.
I would say I totally agree, Rafa. I think that we can't treat them the same, although we don't have clear guidelines around that, but I'm similarly permissive. I'm not as concerned about it. And again, and systolic volume, I think, is also very important.
If we move to the next one, what we offer, this is a very, very good question. I think we have to treat the pulmonary valve now as a lifespan disease. So it's a patient that's going to have several interventions, and whichever intervention, we just think that we're going to have an operation now or whatever we offer now, but it's going to have another one afterwards. So we need to use the combination of the percutaneous and surgery, along the lifespan of the patient, using the one that is more convenient at the time. The problem we have with or I personally have with the self-expanding valves in native outflow tracts is that we don't know what is the long-term complications of this valve is going to be. It's a huge valve in the outflow tract. It's the benefit of you can put valves inside, and probably you can put 2 sapiens inside. That's going to be okay. The concern is that those that have an altera that is going to damage the pulmonary artery, patients with a very large harmony valve is going to be a problem in the pulmonary branches. It's going to be a problem in the outflow tract. What is going to happen with the VTs? All of this is something we are learning, but I think we should implement the technology we have, thinking about the lifespan of the patient. I think if you have as much as I think that the younger the patient is, the more likely to offer surgery, but equally, if you have a 25 years old that is in the middle of school and definitely cannot afford 6 weeks of post-op recovery, and it's a perfect candidate for a harmony, I would have no objections to give him a harmony valve. I think it's in a case-by-case how I think we should decide in the pulmonary valve. As having said that, I think if you can operate a patient that is young, probably. And also depends what valve you have there. If you have a previous valve and it's small, I would not put a valve in valve. I would put a bigger conduit. But you have a native outflow tract and it's suitable for one of the new self-expanding valves, I might offer that as a first step. And then I know the next one is going to be an operation, but just combining the technology we have.
I'd agree with all of Rafa's comments. I think we're still kind of learning with the harmony valves. We've been doing them here for a couple of years. I know you've been doing them much longer in Toronto, and it really does kind of come back to patient preference. I mean, my basic approach is to see whether we can put in a new surgical valve in the younger patients as big as possibly can, so that we'll be percutaneous for the rest of their life. But like you say, there are some cases where we've got people who are younger who don't want to take all that time off work, or it just doesn't work for them.
May I just ask a question? But the threshold for intervening would not differ if the patient can have a percutaneous valve versus a surgical valve, or otherwise would you wait longer for a surgical intervention than you would wait for a percutaneous approach?
So from my perspective, I would say that I would use the same cutoff. And then really, if you think that somebody requires an intervention, then looking to see what the best intervention for them is based on their candidacy for a percutaneous option and their choices and all the other sort of patient-specific considerations. I would not intervene sooner if they were a candidate for a percutaneous valve. I would use the same criteria.
Yeah, locally here, we haven't dropped our thresholds for percutaneous. Yeah, I don't think you can say that.
I think that we do for primary stenosis, but we're more severe If a patient cannot have a percutaneous option for a pulmonary stenosis valve, then yes. For a pulmonary regurgitation, I don't think we don't do it. And I personally think that the criteria should not be different. I think personally, we've been focusing too much on volumes and trying to recover volumes, but I think what we need to think is we are treating a patient that what we are trying to achieve, or at least is what I think we should achieve, is to preserve the systolic function of the RV, which is going to be what is going to determine the prognosis of this patient long term. So whatever, if the systolic volume is very large, it means that already that RV function is not okay. So I don't mind. You know, it is no difference whether I'm going to offer him a percutaneous valve or a surgical valve in order to decide to offer him something. The criteria for us is the same. In terms of how to follow this patient, just to continue because we are just almost on the time. So if they receive a pulmonary valve, these patients should be followed yearly. In terms of the complications, just, well, you know, is this theory or there are data that all pulmonary valve, percutaneous valve have a higher risk of endocarditis. We don't have the similar data yet for the new pulmonary percutaneous valves that they have a higher risk of endocarditis, but every patient with a bioprosthetic valve in pulmonary position has a higher risk of endocarditis, that's for sure, and therefore you know, it's important for them to educate them in that area or aspect of their life. And yes, of course, they can have a deterioration of the valve and can have a stenosis again and regurgitation again. This valve they have a lifespan of about 10 to 15 years, and they will have to have another operation again. Some people, you know, they would choose not to put a percutaneous valve for the risk of endocarditis. I think, as I said, yes, the Melody clearly had a higher risk of endocarditis. I don't think we have the same data for the rest of the valves, including the Sapiens. So that's not a criteria that I would give somebody a percutaneous valve regardless of the risk of endocarditis, because I don't think we have yet data to think that is higher. With the new valves, maybe in the future. I will leave the pregnancy question to I'm going to give it to Jasmine.
Yeah, so I think as far as pregnancy is concerned, it's a regurgitant lesion. Really the way I sort of look at it is, does this patient warranted intervention independent of pregnancy? And the answer is yes. And so I would move forward with that. Then there's the discussion around putting in, you know, whether it's transcatheter or surgical valve, is the longevity of that valve affected by any given pregnancy? I think that, you know, perhaps there's some data to suggest that may be the case, but it is not definitive by any means. Having said all of that, regurgitant lesions are generally well tolerated in pregnancy, so I anticipate that PR would be well tolerated. But if they're already having symptoms, and now I can't remember if they are or not, then you know, I think that you would want to deal with that before pregnancy. And then in terms of contraception for someone like this, it would be progesterone only contraception, whether that's an IUD or a patch or oral with valvular disease.
May I ask why you would suggest progesterone only? Do you think the thrombotic risk is so high in pulmonic regurg, or what would be the rationale? Yeah, so I think that anytime someone has a valvular lesion, so more so on the left side, to your point, you know, you worry about thromboembolism, but also risk of underlying arrhythmia that may or may not be detected. And so if they can tolerate a progesterone-only formulation, which is just as effective, then I err on the side of caution. But if for some other reason this particular person needed combined contraception, this is not the worst. This is not the sort of the highest risk, you know, in terms of a cardiomyopathy or a mechanical valve. Like I would be worried more in those patients.
Joanne, do you want to tell us what happened with this patient?
Yes, of course. And first of all, thank you so much for the panel for answering all my questions and for clarifying the severity of the pulmonary regurgitation on MRI. That's a great learning point as a trainee for me, and to also not blindly accept numbers, but think about remeasuring them. So thank you for that. So this patient was discussed, and ultimately, given the patient preferred no intervention given the asymptomatic status, so he was planned for close follow-up, and he's awaiting next sort of a close follow-up and imaging. So right now he's asymptomatic and doing overall well.
That's great to hear, Joanne. Can you tell us a little bit more about the close follow-up that's planned?
I think maybe Dr. Schwerzmann, you can add to it as because I'm not sure in terms of, I know there's a plan for echo and ECG in a couple of months to be done. I'm not sure the duration at which we would do the follow-up for this patient.
I think he's booked for an annual follow-up. So we will see him again in 1 year's time. We will repeat the echo. We will see how he's doing. If we have the impression that his exercise capacity may have reduced, we may repeat the CPET study, and the cardiac MRI we will repeat roughly in 2 years' time from the last MRI. And we also looked at the MRI numbers, and I think as you all said, I guess the numbers on the most recent MRI, especially the end systolic volumes, were actually measured too big. So in the end, also on the MRI, his RV ejection fraction was better. It was still not completely normal as we had it on the echo, but on echo, really in all views, on the short axis view, on the 4-chamber view, everything, RV function looked fine. And given his excellent exercise capacity for peak VO2 of 48, we decided that at this point in time we accept, of course, his decision, and we just continue to follow him closely with non-invasive investigations.
Important to listen to patients' decisions too. Patient's choice is important.
Yep. Maybe if we have time for one additional question, I think in the chat, Dr. Patterson wrote regarding MRI and assessing pressure half-time or flow velocities on MRI, that we can also, like we can have on the echo, measure pressure half-time, we can theoretically also on the MRI take a closer look at the flow. Is this something Jonathan, you routinely do when you do MRIs in these patients, or what would be your MRI routine for a pulmonic regurg like this one?
Yeah, so Ian's exactly right. So you can look at the flow profiles, and you can actually get a lot of information from that. And you could even a lot of this is not done routinely in a standard cardiac MRI. But for instance, we use this a lot in congenital, where we actually do look at the flow measurements, and you don't have the temporal. It's true, you don't have the temporal resolution that you have with your Doppler, but you do get a lot of useful information. And certainly, having trained with Shijun to kids, we're very, very focused on flows, and we use those flows in the assessment of hyperplastic left heart syndrome, and can get lots of valuable information. For instance, when you do the short, when you look at the flow at the ascending aorta and descending aorta level, at the level of the RPA on an axial cut, you can actually get the left upper pulmonary vein, and we wrote about that like 10, 15 years ago, about the flow profiles you can get. You could even, to your point on hepatic vein flow, you could contour, do the phase contrast through the hepatic veins and show the same flow profiles that you can show on echo. It's not routinely done, but we can do it, and people have used that as the flow in the pulmonary veins as a way of looking at diastolic function in MRI. Like I say, it's more kind of nuanced, but it can be done.
Okay, I think if there are any questions. I think we're now in the Q&A in the Q&A section. So if there are any additional questions, please write them in the chat.
As people are writing their questions, we, in this case, really talked about the critical role of the MRI in guiding decisions in addition to symptoms and exercise testing. How do you approach it if patients, for one reason or another, cannot have an MRI in your center for determining the volumetric criteria?
Well, you could do there's a couple of options. There's 3D echo options. That you can use Tom technology, or you could use Ventripoint, which is a knowledge-based reconstruction model where you make multiple 2D echo with magnetic tracking, and you can make a 3D model, and that's quite good. The other thing is you could do ECG, a CT. You could do CT gated. Where if your radiology department does gated CT, which will work out your ejection fraction, do your end diastolic and end systolic volumes.
We normally use CT with we have a new software for CT volumes, which is quite accurate. The thing is, what I find it sometimes is overestimates the volumes more than you would expect. How I use it is just to see progression rather than a number. That's because normally the error is the same, but the CT, in my experience, overestimates the volume more than the MRI and give you, therefore, it's more worse ejection fractions. But in terms of longitudinal follow-up, I find it helpful in patients with pacemakers that you cannot do an MRI. So. Or if you do MRI, it has so much artifact that you can really measure volumes in the heart rate. So.
I would say, though, that, and you probably found this as well, Sarah, that there are a lot of people that we say that they can't have an MRI with a pacemaker. Well, we actually can do it. And I know Ian's on the line, and Ian did a lot of work from us locally when Ian was here in the Mazankowski to create that floor pattern where we could get most of our patients with pacemakers done. It's just the epicardial leads that we're still not doing.
Okay, I guess I don't see any additional question in the chat. So I guess I would like now the opportunity to thank you all for being part of this ACHD rounds, especially for Joanne for preparing the excellent slides for the presentation. And before I give the word to Sarah to say goodbye, just one additional remark. Our session now is ended, but you can, if you would like, you can stay in the of course in the rare congenital rare disease conference till 5 o'clock, and at 5 o'clock we have one more words from Dr. Patterson, Dr. Byrne. He organized the congress. If you would like, we're happy to invite you to stay till then. And if not, well, thanks for having joined us. And now back to you, Sarah.
Thanks. I would like to extend a thank you as well to Joanne. Those quizzes were great to prompt discussion, and also really nicely highlighted that although patients have simple lesions, the decision-making can be far from simple and needs to be integrated and nuanced and reevaluating the data and incorporating the patient perspective. So thank you for those great cases that allowed such a rich discussion by our panelists. And thank you again, Drs. Alonso, Windram, and Grewal for joining us. This is an outstanding session, and I was really pleased to be a part of it. So thank you all so much.